Good afternoon. I'm Ruby Moore. As a member of the NARPA board, I'm pleased to welcome you to NARPA's second in a series of 4 presentations on critical issues that are particularly relevant right now. Because of restrictions due to COVID-19, these presentations are happening over the next few months in lieu of NARPA's annual conference. Today, we're delighted to have 2 leading civil rights activists and attorneys, Kathy Flaherty and Jennifer Mathis. Jennifer and Kathy will be talking to us about Olmstead and the ADA during the time of COVID and the impact on people confined in psychiatric hospitals and other congregate settings. Kathy Flaherty is the executive director of the Connecticut Legal Rights Project and a current NARPA board member. Jennifer Mathis is the Director of Policy and Legal Advocacy at the Bazelon Center for Mental Health Law and a longstanding leader at NARPA and former board member. Please welcome our distinguished presenters. And first up is Kathy Flaherty.
Thank you, Ruby, and thank you everybody who is attending this webinar today. If we could advance the slides. And next slide. We are going to be nope, just back one, please. I really want to start this conversation centering the women at the center of the Olmstead case. I am a person living in recovery from a psychiatric diagnosis. And as a lawyer, it has always kind of irked me that this case is known by the name of the governor of Georgia, who was discriminating against the people in Georgia institutions. So I want to just take some time and I will go through and describe the pictures that are on the screen. But these are the women of Olmstead are Lois Curtis and Elaine Wilson. Lois is the LC in the case caption. Their lawyer is Sue Jameson. And of course, we must acknowledge Ruth Bader Ginsburg, who authored the decision. So going from the top, clockwise from the top of the screen, there's a picture of Lois, Sue, and Elaine at a panel. To the right of that is art that Lois drew, showing the 3 of them. The bottom right corner is another photo of Lois with a huge smile on her face with a self-portrait and a portrait of Elaine. The middle is shared by 2 pictures, which is one where Lois is presenting some of her art to former President Barack Obama. And below that, the official portrait of Justice Ginsburg. And then a picture of Elaine and a picture of Lois. And those 2 portraits in the lower left corner were taken by Tom Olin, who has photographed so much of the disability civil rights movement. While we have their pictures on the screen, I want you to hear the words of Lois and Elaine, because as lawyers, the thing that we may sometimes forget is that we can't have a case. We can have all the legal theories we want, but we never have a case until we have a client. And Lois and Elaine put themselves out there as the clients for this case. So a little bit about Lois. She grew up in a public housing project. She was diagnosed with intellectual and mental disabilities. She often got in trouble at home and at school. The police were called several times and they would take her to a jail or a psychiatric hospital. The fact that we're still having those conversations today, it tells you that not much has changed. I think the most remarkable thing is that when she went into the Georgia Regional Hospital at 11 years old, a hospital she would remain at until she was 29, the hospital opened in 1970. And so in her own words, when she was asked, what do I hope for other people in institutions, is, I remember you. Give me a prayer. Sometimes I feel good about my life. When I feel bad about my life, I name my country, sing the gospel, and bring my mind back home. I will sing with you again. Have a beautiful day. Love, Lois. Elaine first went into an institution when she was 15 and cycled in and out of institutions, 36 different institutions. She finally rejoined the community, where she remained until she died in December of 2004 at the age of 53. And in the words of Elaine, when I was in an institution, I didn't like myself. I was trapped. I had no hope. I thought, oh God, when am I ever going to leave here? And at the hearing in district court, after the Supreme Court decision, she testified, when I was in the institution, I felt like I was in a little box and there was no way out. Next slide. So even though it seems like we've been living COVID-19 and that this year has lasted for 1,000 years, I want to give a brief overview of the timeline, especially as things happened in Connecticut. On January 30th, the World Health Organization declared a global health emergency. On February 29th, the United States reported its first death due to COVID-19. On March 10th, the governor of Connecticut, Ned Lamont, declared a civil preparedness and public health emergency. On March 13th, the President of the United States declared a national emergency. On that same day, the Connecticut Department of Public Health restricted visitors to nursing homes and other congregate facilities. Next slide. On March 15th, which was 2 days later, the governor's executive order authorized limits on visitors to facilities that treat persons with psychiatric disabilities. Connecticut has in our state statutes a patient's bill of rights that applies in inpatient and outpatient psychiatric facilities. And one of the rights under the patient's bill of rights is the right to have visitors. The governor's executive order was issued on March 15th, but it was not until 2 days later, on March 17th, that the commissioner of our Department of Mental Health and Addiction Services, that's abbreviated DMHAS and pronounced DEMAS, issued her first order restricting visitation. She issued a memorandum regarding the restriction on visitors to DEMAS. Those are state-operated facilities. She also wrote a memo that was published publicly to conservators and family members regarding that visitation policy. Next slide. On March 24th, the first employee of the Department of Mental Health and Addiction Services tested positive. March 26th, the first patient at Connecticut Valley Hospital, abbreviated CVH, that's our big state hospital that's located in Middletown, Connecticut, tested positive. 5 days later, March 31st, the department announced that 5 patients at our forensic hospital, Whiting Forensic Hospital, abbreviated WFH, along with 5 patients residing at Connecticut Valley Hospital and 2 staff at Connecticut Valley Hospital had tested positive. On April 2nd, Connecticut Valley Hospital closed its patient detox unit so that they could use the space for other purposes, including some isolation. April 30th was when the department announced the first death of a patient that was related to COVID-19. Next slide. On April 30th was the date that Connecticut Legal Rights Project filed its lawsuit in federal district court. A week later, we filed an amended complaint, and that's when Connecticut Legal Rights Project was joined by attorneys at the Avalon Center for Mental Health Law and the Center for Public Representation. On May 15th, the second patient death was announced. On May 21st, the third. On May 22nd, the fourth. And on May 27th, the fifth. And at this point, I am going to turn it over to Jennifer. Right before she comes on screen, I want to make clear to everybody that the challenge that the team at CLRP took on was done while, like all of you who are working in offices, we were working remotely for the most part. There have been some people on our staff who have worked at the in the office in Middletown every day. I personally have been sick since March, so I am just incredibly lucky to get to lead a team of such incredibly dedicated advocates that I could say to them, do what you need to do to protect our clients. I said very early on in this pandemic that if you think about what an inpatient psych unit is, and I know because I have been there not only as a lawyer, but also as a patient, they are not designed for social distancing. They are not designed for people to stay safe. They were fairly low on the list for distribution of protective equipment. And it was scary. I mean, we knew early, you know, one of the reports that came out of South Korea was of a number of deaths in an inpatient psychiatric facility there. And we know that other institutions, especially psychiatric facilities, have been the site of a lot of transmission of the virus and a lot of people getting sick and unfortunately passing away. And we hear a lot of conversations about nursing homes, a lot of conversation about jails and prisons. You obviously have all the workplace things because certain workplaces are not set up or set up for ideal transmission of the virus. But we don't always see, and it took a really long time before you started seeing a lot of public discussion about what was going on in psychiatric hospitals. At this point, I do want to turn it over to Jennifer, so I am going to turn my video off. And Jennifer, it's yours.
Hi. So I just want to take a step back for a minute and talk a little bit more about sort of the national context. And I will talk a little bit about how COVID has impacted a lot of the work that was already underway with Olmstead settlements or proactive Olmstead implementation efforts, as well as you know, some new work that has been done, even where there weren't particularly Olmstead implementation efforts that were significant, that were happening, that because of how the virus has impacted some facilities and the outbreaks and the deaths that have happened, that we've seen kind of a new wave of what I call sort of COVID deinstitutionalization work. Which there have been a number of cases filed concerning mostly state psychiatric hospitals, some other facilities as well. And I don't want to get too wonky and too legal, but I just want to talk a little bit about kind of what the world has started to look like, what's happened, and you know, what some of the lessons learned have been, and where we may go from here. So you know, Kathy started with Olmstead as sort of the frame, and I think that's right. And we think of Olmstead as sort of a, you know, a civil rights obligation, right? It's the ADA, the Americans with Disabilities Act, integration mandate. It is a civil rights law, and it's the Supreme Court's interpretation of that civil rights law. And, you know, I think how we have always thought about people who are people with disabilities who are served in institutions who don't need to be there, in that they, you know, in many cases could succeed and thrive in the community, in their own homes with support, that's a civil rights violation. But we sort of moved with COVID from, you know, civil rights violations and all the concerns attendant to those kinds of violations, whether it's a nice institution or not a nice institution. There are a lot of things about institutional living that are, by their nature, difficult and oppressive and really circumscribe people's lives in, many ways that are hard to live with. And frankly, that as the Supreme Court also said, perpetuate stereotypes, perpetuate unfounded assumptions about those people that, society takes on. Because you were there, because you lived there, there must be something wrong with you. You must belong there. You must belong in a place like that. And so I think on top of all of that, now we have, these places have become death traps. And I think all of us were reading the newspapers with increasing alarm. The focus was primarily on nursing facilities for a variety of reasons, I think, but it was pretty clear, I think, in the first few weeks, and became clearer and clearer, that a significant portion of the deaths from COVID in the country were happening in nursing homes, psychiatric hospitals, other psychiatric facilities, group homes, institutions for people with intellectual and developmental disabilities. And we saw, I think, many, as Kathy suggested, many public outcries about prisons and jails, and there were a lot of efforts to decarcerate. I was actually heartened and surprised by the impact, the extent of the decarceration efforts, and you saw many facilities decrease their jail census by, as much as even half, 30% more than that, half in some cases. And so that was pretty significant. And yet very little attention continued to be paid to actually getting people out. There was sort of attention paid to the fact that people were dying in congregate care facilities, but really there was virtually no conversation about, what do we do about that? And, how do we get folks out the way that, seemed to be a no-brainer in the context of prisons and jails. And so anyway, we, I think, really found this difficult to watch in our existing Olmstead cases. And, we had people dying in so many of our settlements. I think in New York, the state came to say at some point, gave a figure to the court about how many people in the class that we had in an Olmstead settlement had died. And it was 4% of the class, which is, a lot of people. And I think there was a sense of real frustration and almost helplessness among all the folks, not only in these places, but the folks trying to help them and communicate with them. And, at the same time as this was happening, what was so particularly frustrating is that the way to get folks out really shut down. The community service system was impacted by COVID as well. And so you had community providers really not functioning, and transitions, even where there are settlements, where there's obligations, there's court requirements to meet certain benchmarks, and all of that was happening. People were moving out in a number of states under these different Olmstead settlements, consent decrees. All of a sudden, things really slowed to a trickle or came to a halt altogether. And some of that has gotten a little better. Some of that was because I think nobody knew how to address COVID at the beginning. People couldn't come in to the facilities. Community providers couldn't come visit people in the institutions to help them transition. People couldn't, at the very beginning, deal with all of the regulatory barriers that prevented people from doing telehealth, and we not only the regulatory barriers, but the infrastructure wasn't set up to do telehealth. People did things in person before, face to face, and the billing required you to do face to face interactions, and so now not only do you have places that have become death traps. It's really hard to do social distancing in a setting where you have people often sharing rooms. You have beds that are not even 6 feet apart where people are sleeping. You have people waiting on lines together to eat meals. You have people sitting in communal dining rooms and eating shoulder to shoulder. You have people going in the elevators together. You have people waiting for medication together. You have people pretty much doing everything together. You have people using communal phones, and the phones aren't being cleaned from one person to the next. And so, and people sharing bathrooms. And so it makes sense that, in these environments that this virus was proliferating. And yet, you had very little opportunity to get people out. And in many cases, admissions continued. Sometimes admissions slowed down for a variety of reasons, but you had, I think, people coming in the front door and really nobody coming out the back door, creating, I think, even more of a risk in these environments because you had greater numbers of people and more crowding. And so even in those cases where, as we talked about, there were requirements, nothing happened for a long time, for many weeks. And, during that period, I wouldn't say that nothing was happening. Obviously, people were frantic, and you had a lot of state folks in different places trying to do a lot of things, and you had different federal guidance documents coming down from CMS, from the CDC, CMS being the federal Medicaid actors, the Centers for Medicare and Medicaid Services. But it was a really, really problematic situation. We can go to the next slide. Okay, so one of the things that I think we tried to do in the cases that I think we had that were already happening, we had some opportunities because we had relationships with folks and an infrastructure that was already kind of in place, which frankly should be in place everywhere, but is not, to help people get out and link people with community services, and most particularly with housing. And employment services and other services that they may need. And so there was, I think, an effort in some places, but for a long time, I think things were stalled because of the uncertainty of the pandemic and how long we would be in this situation and what might change. In those first weeks, I think it was helpful that we saw both at a federal level and a state level, a lot of the regulatory barriers to doing things through telehealth, doing things either through a video system or a phone even, were lifted. So, you could bill for that, so people could at least communicate and not leave people completely isolated. There were lots of issues still around telehealth. It's not like when the barriers were lifted, all of a sudden everybody did telehealth and it worked and everyone was happy. I think there were lots of struggles, and in some places continue to be lots of struggles about how you're going to do telehealth, what is actually working for people, what kind of system you're using, if you're using a video system, and whether you're talking about smartphones or laptops or something else. People don't have them in the institutional settings for the most part. And so there have been efforts in many of the states where we are working to get those to people, to get phones. In some cases, I think the problems have been so basic that boxes of phones are dropped off, and yet they don't get to the residents in those institutions. But beyond that, I think there are many issues of who's going to help somebody learn to use a phone, a different kind of phone, a smartphone, use the video capacity. In many cases, you had residents teaching other residents how to do it. You have internet reliability issues in some phones. So there's so many factors that have made this something of a challenge. They're not insurmountable factors. They should be doable, but I think we are watching that happen, and I think urging for things to happen far more quickly than they have been happening. And then some things, many things can be done on the phone or on a video. Things that people aren't necessarily thinking about, like, people used to go out always and look for apartments, and someone would help them often and drive around and look at different places where the person might want to live. And, now that stopped happening in many places. It's happening to some extent with PPE, but in many cases it's not. But you can do virtual tours. That takes some work too, to get somebody with a tablet or a smartphone or something into a place where someone can actually get online and look at a bunch of apartments. That can happen, and that has been happening in a bunch of places. So starting to happen in some places to get back on track. Some things can be done, arguably, with a video assessment, like, what used to be a face-to-face assessment that, is usually required in order to decide that somebody can leave and, go to their own, transition to their own apartment or other setting. That should be able to happen by telehealth. Some places are going to allow that. Some places seem like they're not going to allow that, but that ought to be able to happen for the most part, I think, by a telehealth system. So I think many of the things that were seen as barriers, like, people are finding ways around them. Some of the government guidance documents still seem to present barriers. I think a lot of people look at the CMS guidance that talked about visiting people in nursing homes or in long-term care facilities and said, oh, we can't visit, community providers can't visit, peer support people can't visit. And I think that CMS is, certainly many of us have been advocating with them to be clearer, that in fact there are situations where people can and should be able to visit, that certainly folks who are helping people transition should be able to visit, obviously with distancing and PPE, but that should be allowed to happen. CMS had an older guidance document that I think created a lot of confusion. And then just a couple weeks ago in September, they issued a new guidance that makes a little bit clearer. I think many of us are urging them to make even clearer, but the newer one seems to say that a wide variety of healthcare providers can come in as long as they're serving, folks in the facilities, and that would include, I would say, helping people get out. And so they ought to be able to do that. And then outdoor visits are an option. They have been an option right now. And increasingly, you see many facilities using outdoor visitation, which is, obviously you still need PPE and distancing, but that is, I think, a good option and safer than, having people come into the facility where you can accomplish the same thing outdoors. That has its limits too in many of these places, but that's an option at least until it gets really cold in some places. And so, I think one of the things that we have tried to urge people is really having a plan in place and not kind of sitting around and saying, well, it's COVID, and so we're not going to do anything, until things change, until we get into other phases. If you don't have a plan in place, you can't begin preparing, you can't do the infrastructure that you need to do, you can't get the telehealth things in place, you can't get the rules in place, you can't, get people trained on what to do if you just sit there and wait, understanding that obviously things are always changing, but still, people have to start planning and can't just sort of sit around on their hands and wait for, something to look radically different before they do anything, because people will otherwise just continue to die. And next slide. Okay, so I want to talk a little bit about some of these COVID-focused deinstitutionalization cases that have been brought. I would say, I think the bulk of them have been brought around folks who are in state psychiatric hospitals. State psychiatric hospitals across the country did have a lot of outbreaks. And I think the earliest case was brought in St. Elizabeth's, against St. Elizabeth's, which is the public psychiatric hospital in DC. And there was already a case that was happening from last year. It was kind of hanging around about the water crisis that they had in St. E's. They had non-potable water for many, many weeks. And so there were these claims that had been brought. And so there was a case on the docket. And I think that people expanded it once COVID happened to say, by the way, now we have a new crisis. And this was really a due process set of claims. It wasn't an Olmstead case, but in the context of state psychiatric hospitals, I think you can have Olmstead claims, but you can also have these, I think of them as Youngberg claims. Youngberg has the same issue that Kathy brought up of not memorializing the name of the defendant, but rather the names of the plaintiffs who brought the case to the Supreme Court. Youngberg was a case in the 80s that was brought by a man named Nicholas Romeo. And, I think it could be called the Romeo case, but nobody then knows what you're talking about anymore when you say Romeo, because like Olmstead, it got turned into, a thing that is about the name of the defendant. But regardless, the point is that these cases involve primarily claims that are directly targeted at getting at safety issues when a public facility, when a government is, hold on, I have a kid who's yelling at me. Okay, I can move on. So Youngberg versus Romeo sets standards. That's essentially a professional judgment standard for when, if a government has people in its custody, as would happen when a government has people confined in a psychiatric hospital, then they owe them essentially a duty of keeping them safe and supporting their well-being. And so these cases have been brought over a series of months, looking at state hospitals where people were starting to die because of COVID outbreaks and insufficient steps being taken to prevent the spread of COVID and putting people at risk of additional folks dying in these places. In St. E's, they moved quickly, and I think that case was brought back in March, if I recall, and maybe early April they were still going, and they had a very quick TRO granted, temporary restraining order, and then a preliminary injunction granted. And those that court case, really, the focus ended up being much more around infection control procedures in the hospitals. And there were some basic things that the court found weren't even being done. And so things like, restricting where staff could go and the movement of staff and residents around the facility, having PPE required, masks, and having people not eat together in sort of close quarters, and all of those things. I think there were a lot of changes that were made between the temporary restraining order and then the preliminary injunction order that made things, I would say, safer in terms of spread of the virus. Ultimately, I think there were about 14 people who died in St. Elizabeth's, which is a pretty significant number. The census is now 130 people or so, I think, or it was a few months ago. That's a really high death rate. But the judge ordered these changes. What the judge didn't really focus on so much was discharging people. And, there were many people, I think there were 56 people that even the folks who ran St. Elizabeth's acknowledged were ready for discharge. But the judge focused on that less, I think in part because St. E's had discharged a lot of people recently and had reduced its census by something like a third. And so, I mean, the judge didn't drop it altogether, and I think required DC to report on it and to sort of talk about it in a couple of months why they did or didn't follow the recommendations that the experts had made, that they do more of a process to ensure that they were discharging folks. And so I haven't followed what has happened with that, but primarily all of the stuff early on was really focused on safety in the hospital and not getting people out. Connecticut was a case that that Kathy talked about, that we are involved with also, around 2 state psychiatric hospitals. 5 people, as Kathy said, died. There were outbreaks. Currently, there are no longer outbreaks. I think one of the difficulties of these cases is if you want to move fast and prevent more people from dying and do something urgently, it's hard to do that without a lot of information, and you don't have time in the process to get the information that you normally would. And so I think we tried to initially move for a preliminary injunction to focus primarily on getting people out and sort of setting up a process to really start looking at discharging people with a different eye than one normally would, sort of bearing in mind the extreme risks of COVID that are posed by having folks stay in the facility. By the time that the state had briefed their response to the motion, I think things had changed. The state had put in place more measures to try to segregate folks, to do testing on a regular basis, to segregate staff to certain units, and to prevent movement in between units, and to have people eating in their rooms and other things. And so the outbreaks seemed to have stopped for the moment by then. I think our experts said that there were many concerns that continued, particularly because the distancing was not possible still to do. But so that case goes on. We withdrew the preliminary injunction motion in order to go ahead and get discovery and move forward with a more fuller exploration of the facts. And in Massachusetts, that case was filed a little bit later. I think folks involved in that case are on the webinar now, and happy for folks to add anything in the chat. But in Massachusetts, there was a case brought as a class action involving folks at Tewksbury Hospital. There were 2 psychiatric units in this state-run hospital in Massachusetts. There were outbreaks there. I think 3 people died. 85 people had tested positive at the time, I think, that the case was brought. And similar concerns. They sought a preliminary injunction. Also, they did not get it. The judge basically said, well, on this record, I think this is again, the difficulty of doing these cases and trying to get very quick relief, because the situation merits that. You don't have really all the information that you would like to have sometimes to explain exactly what is happening in a system and what could happen differently. And so I think that, they're still moving forward without the preliminary injunction, but they have Olmstead claims as well. There are Olmstead claims in the Connecticut case. And then lastly, there's a case in California that was brought also as a class action. And I think that case is around people who are in Patton State Hospital in California, which is, I think, 1,500 people. It's one of the largest state psychiatric hospitals in the country. And there were outbreaks there. I think there were at least 2 people who have died. That case was brought in August, and so that case is pending now. And there, I think, are settlement discussions that may be happening there. If we can go to the next slide. I want to talk a little bit about some of these other contexts in which people have brought COVID-related deinstitutionalization cases. We talked a little bit about the prison cases. There are actually some people, I think, secured some early legal victories. And then there's some mixed cases, but certainly there were some cases where judges required significant decarceration from jails or prisons because of COVID outbreaks. There are a number of cases around veterans' homes. There's a lot of state-run veterans' homes. Primarily, as far as I have been able to see, those are tort claims. You can't bring an ADA Olmstead claim against an individual facility. You could, bring it against a public entity, but private facility, a nursing home, doesn't have quite an Olmstead obligation. They may be covered they are covered usually by Title III of the ADA, but Title III doesn't really get you much of an Olmstead remedy unless the facility also happens to run a community service system, which typically they don't. So I think that some of these veterans' homes have settled, and some of these cases are still going on. I think there are actually criminal charges brought against one of the veterans' homes. And then I just wanted to mention there is at least one case I know of around private adult homes. In New York City, there's an adult home called Queens Adult Care Center, where they had outbreaks and I think a number of deaths, and it was written about in the paper. And so there's a law firm that brought class action ADA Title III claims. And again, you can't really, I think, get a discharge remedy with Title III, ADA claims that are just against a private facility if they don't also run the community-based services you're talking about. So I think the nature of these claims, it seems to be something like there are reasonable accommodations that need to be made for people with disabilities in these facilities in order to keep them safe from COVID, and you're not making those accommodations and you're putting them at risk. But I think that has less to do with actually getting people out than it has to do with just changing processes in these facilities. Next slide. So as I mentioned, the main theories for the public facilities have been these Youngberg claims, or claims that are due process claims, that once you've got someone in your custody, you've got an obligation to keep them safe. From the Youngberg versus Romeo standard. The standard typically is professional judgment. I would say in Massachusetts, there was I think a higher standard that the plaintiffs argued applied based on Massachusetts law. And I think there was a dispute about that between the plaintiffs and the state. But otherwise, I think in these other cases, you're talking about this professional judgment standard. And for professional judgment, I think there are some important things to look at. And there are infectious disease controls specialists in most of these cases, as well as experts who have knowledge about mental health service systems, and how to discharge folks promptly, and how to kind of create the infrastructure to do that well. So, some of the things that people should be aware of are the CDC guidance documents. They typically talk about nursing facilities. Some of them focused on long-term care facilities. The courts have generally applied those to psychiatric hospitals as well. One of the most important things I think that those documents do make clear is the distancing requirements are so critical in these facilities. And so there's professional judgment looking at sort of the CDC guidelines, looking at, I think, CMS, looking at what the infection control policies that CDC sets out are, including having testing. I didn't put testing in here, but I think, something like testing every week is maybe what they've said. I've lost track of what the current standard is, but I think in some places it was actually twice a week that they were doing testing of all staff. I'm not sure if that was true of residents too, but I think CDC had said every week, at least where there is community spread. And then certainly CDC has standards about also PPE, mask wearing, cleaning practices, disinfecting surfaces with a lot of frequency. In some of these places, you had, bathrooms that weren't being cleaned during the weekend when staff were apparently off, and nothing was happening in terms of cleaning, and that was obviously a problem during, particularly during COVID. So those are some of the guidance documents that one might look to for figuring out what, whether professional judgment is being met. If we can go to the next slide, I wanted to mention one other that I thought was pretty significant. So SAMHSA this year actually issued a statement about the pandemic, and I thought it was important that I've never seen SAMHSA say this before, but they said because of the substantial risk of coronavirus spread with congregation of individuals in a limited space, such as in an inpatient or residential facility, outpatient treatment options should be used to the greatest extent possible. And they also said inpatient facilities should be reserved for those for whom outpatient measures are not considered an adequate clinical option, i.e. for those with mental disorders that are life-threatening. So life-threatening, I think, is sort of a different standard than what most people are using for, whether or not they should discharge somebody and whether that person can be transitioned to the community. So that was pretty significant that SAMHSA is saying that you should not be using inpatient care except in life-threatening circumstances. Next slide. Okay, so other claims, and I just actually also want to say that one of the other things that I think is happening in these places, actually maybe part of my slides later, no, I don't think so, is it's just that, not only are people unsafe, but the quote unquote treatment that people are getting in these facilities, I think has diminished very significantly in many of these places, as they're on lockdown, and, you're not getting a whole lot of treatment. And that has to factor into the analysis as well. I think the justification for keeping people in some of these congregate settings at risk when, they're not getting a whole lot while they're there other than being, sort of confined, really, I think, lowers any justification that one might have for insisting on keeping folks there. I think the issue is really the challenge is sort of, getting the community system to a place where, you can get people housing, et cetera. So just wanted to mention, I think I already talked a little bit about these. There are Olmstead claims that are brought. There are, besides these due process, Youngberg type claims, Olmstead claims, but Olmstead claims are a little bit less directly tied to COVID itself. I think they're just, the same claims that you would bring COVID or not. COVID, has some, I think, creates more urgency around them and more of a reason why it's so critical to ensure that people can get out, both to reduce the census in the facilities as well as keep people safe outside of the facilities. Other ADA claims have been brought, like in the adult home case, that Title III ADA claim. I am not sure really where that's going. There are state law claims in some cases, negligence claims primarily, and I mentioned there are criminal charges in some of these cases. Next slide. Just wanted to mention some of the challenges of bringing some of these cases for the lawyers who are listening on here. I think, having your experts come in is a very different enterprise than it might be in other times. And so I think, in many cases, you really need to have the judge set out an order that sets forth expectations under which that person can safely go in, and how that all has to be done. And it has been done in some cases, and in DC, I know in the St. Elizabeth's case, one of the several of the experts actually went in and did tours, but with a whole lot of PPE and under a whole lot of conditions. Record reviews, it may be a whole lot easier when there are electronic records for people to review patient records if they need to, because they don't need to be there sitting in the facility. If they're not electronic records, makes it a lot harder. Obviously, a lot harder to spend time visiting clients to figure out what's going on. You can talk to them on the phone, hopefully, but that makes things challenging also for plaintiffs bringing these cases. Next slide. Okay, so where are we trying to get to with those types of cases? And even if there's not a case, sort of what should we be doing? Certainly changed infection control practices are important in terms of PPE and testing and how often the testing is happening, segregating people, cohorting people in safe ways, obviously. And, some of the problems I think with doing some of those measures is they're important to keep the virus from spreading and to keep people safe, but they also really can make life pretty miserable in these places, which is why I think, apart from the usual civil rights concerns, getting people out is important. And also, certainly for distancing purposes, getting people out is key to enable people to actually have 6-foot distancing in these places. And then discharge planning, when I say with a different eye, part of that is sort of factoring in the dangers that now exist in these facilities due to COVID, and thinking about that SAMHSA standard too of how we should only be using inpatient care where there are life-threatening circumstances, factoring in the circumstances that people aren't really getting many services in many cases in these facilities, and people are isolated, and people are kind of living along a hallway, and not having a lot of activity, and sometimes can't leave the facility. And it's not only an awful way to live, but it's a reason for people. It sort of takes away some of the justification of people needing to be there. Next slide. Actually, I think that's maybe it. And so, some of the things, just speaking to discharge planning, that I think people are thinking about are, exploring options that weren't necessarily explored before. I think people being more active in exploring with folks, friends, and family, whether they might move in with them. Obviously, family can be very fraught, and there are many reasons why someone might not want to move in with their family, and why that might not be a good situation. But there are also and in some of these cases, there were plaintiffs who had families who, they wanted to go live with, and the family was willing. And so I think some of what has been suggested is exploring, whether in the situations where it actually would be a good match and where the family could take somebody in for a while, just to get them out of a COVID-ridden institution, even if as a temporary measure until that person can get housing. Are there supports that, the state could provide to the family, financial support or case management or something else that would assist with, discharges to settings that wouldn't otherwise have been considered? Are there FEMA funds that, in Connecticut, certainly the governor had put in a request, declared an emergency, and got FEMA funds. And in many cases, they are being used to house homeless people in hotels. There doesn't seem to be a bar on FEMA. I think it's Category B funding being used for, if the state chooses to serve people coming out of institutions until they can get housing. And so that may be an option as well. All of those things should be explored. There are new HUD mainstream vouchers that are attached to a person and not to a unit that should be used. There are more that were just put out recently because of COVID. And so those are some of the things that people should be thinking about in sort of bringing to policymakers to try to get more people out now so that people can stop dying. And I'm going to stop there because we wanted to leave the last half hour for questions. And I haven't been seeing if there are questions in the chat.
So thank you, Jennifer. We have 9 questions currently in the chat. And if folks have other questions, I'd ask that they please, not in the chat, in the Q&A. If you have questions, please put them in the Q&A and I will read the questions as they come through. We currently have 30 minutes. The first question is, can you provide a short explanation of what Olmstead is about?
This is Kathy. I actually apologize to everybody on this presentation. I know that sometimes I forget that not everybody I'm speaking to knows everything I know. And that was supposed to have been something I needed to do at the beginning of the presentation. The Olmstead case is a Supreme Court case. The decision came out in 1999, and it was a case in which the Supreme Court held that it was unlawful discrimination under the Americans with Disabilities Act to keep somebody unnecessarily segregated in an institution. And the court held that public entities must provide community-based services to people with disabilities under certain circumstances. 1, when the services are appropriate. 2, when the person doesn't oppose community-based treatment. So the Olmstead decision doesn't force anybody out of a hospital, an institution, who doesn't want to leave it. And third, community-based services can be reasonably accommodated And then the key thing is for everything related to the Americans with Disabilities Act, taking into account the resources available to that state, and the needs of other people who are receiving disability services from the state. So there's always been an issue with decision is that it didn't come with funding or with resources. So that's always a challenge. And I think Jennifer can probably talk more to that when you're doing this kind of litigation based on the ADA. But I apologize to everybody who didn't know at the beginning of this what Olmstead is. And I hope my internet doesn't go out. Unfortunately, it's been a little wonky here this afternoon. So hopefully people now understand what we mean when we talk about the Olmstead decision.
Thank you, Kathy. The next question, is it possible that hospitals, psychiatric facilities, institutions, group homes, and prisons could provide for taking of temperatures for staff members in order to avoid getting COVID?
Yeah, so this is Jennifer, and I would say yes, I think that is happening to some extent, and yes, that helps, but certainly, taking somebody's temperature is not by itself, a sufficient preventive measure for people getting COVID. Many people, don't have elevated temperatures, and many people are asymptomatic. And I think that speaks to why, you really need testing and not just taking people's temperatures. But I think that they have, in at least many institutions, been doing temperature checks, and that is some kind of measure. But it's, when you're talking about the magnitude of the risks, you really got to focus on all of the measures and not one.
Thank you. Next question. To honor all that is Olmstead, will you create a bill of law to require personal care attendants to be paid a living wage? I cannot live in my home without a personal care attendant. Since COVID-19, it has been incredibly hard to find a PCA because of their low pay rate. My care is worth more than sub-minimum wage.
This is Kathy. I absolutely agree with the person who wrote that commenter. I think everybody who's working deserves the dignity of a living wage. I think everybody in society deserves the dignity of a source of income that is livable, because you've got sub-minimum wage still legal for people with disabilities. You've got people who are on SSI living in poverty, and we need to do better as a society. I do know that in some states, like the state I live in, Connecticut, personal care attendants are unionized, and they have bargained for higher wages, and they have the protection of that collective bargaining agreement. Whether that's the entire solution, I'm not sure it is, but I couldn't agree more strongly with the person who made that comment. So thank you.
Next question. Are there coalitions bringing cases in ICE detention centers? How can disability laws help these cases?
Yeah, so I can speak a little bit to that. I don't think that either Kathy or I are involved in that, but I know that there are a group of disability rights lawyers who are working with immigrant rights lawyers, I think, who have brought a case against ICE. I know there is litigation, I think, apart from that, that is trying to get people out of the ICE detention centers and change policies, specifically in response to COVID. I think the disability rights litigation is about accommodating people and getting people, like, not ignoring people's disabilities in these ICE detention facilities. I know that we actually got involved in representing kids in ORR detention, kids with mental health disabilities, and trying to get them out and get them placed with families. And, you know, now that problem has been overtaken in some way by the even larger, you know, problem that like people are just dying in those places, kids and adults. But I mean, I guess the bottom line is there are a bunch of different pieces of litigation. National Center for Youth Law actually is involved in a number of kids cases, including that Flores litigation that has been going on for a long time. And then as far as the ICE, I think that Amy Robertson is on this webinar. And so Amy, I think, might be able to speak or put in the chat something about what is happening with the litigation that you all have for accommodations for people's disabilities who are in ICE detention. I am not sure if there is an Olmstead component to that litigation to basically try to get people out. I think it's a little bit easier for kids because there is kind of an obligation also in the trafficking laws that kids shouldn't stay in those places. But I think, you know, there is, I think 504 creates an integration mandate for adults as well. And I've been interested in that, but I don't know if that's part of the litigation that has been happening. You know, I don't know what the status is of litigation that was focused on COVID safety and ICE detention. So anybody else who is involved, please feel free to put stuff in the chat.
I'll keep an eye on the chat and read it if necessary. Next question. If the priority was to get people out of institutions, where did they go?
Yeah, and that's a great question, of course. And I mean, you've got to have community services available. And I think it's really the housing piece that has been the most challenging. You know, in some cases, I think we've talked to folks and it's not like there are no services and there is no housing. If you provide housing subsidies, it will open up a lot of housing, make housing more affordable. I know that, you know, states are cutting services now because of the funds that they've had to spend on COVID. So, you know, yes, it is not the easiest time. But you know, you are serving people at greater cost often in an institutional setting. And so, you know, if you actually closed a bed behind a person and, you know, provided more rental subsidies, I mean, you can, I think, free up more housing. The problem is not so much that there's just not absolutely any housing that exists in most places, it's that it's not affordable, accessible, etc. But you can make it more affordable and you can create, you know, more housing opportunities by using some of those subsidies. But that is also why I suggested, you know, really taking advantage of federal options that are available, of using the FEMA funds, of using HUD mainstream housing vouchers. And I know there are long waiting lists for Section 8. You know, there's been more federal housing subsidies that have been allocated as a result of some of the COVID relief stuff, but, you know, never enough. But I think it is not impossible to do things. And certainly in some of the places we've been, community providers have said, we could serve some of these folks and we could help them get housing. You know, we can do this. There is no reason for all of these people to be sitting here. So while I do think it is challenging, I don't think it is impossible.
This is Kathy. I just want to supplement that answer a little bit by just saying that a lot of this is efforts that we have made for quite some time to have states make additional, consistent, long-lasting investments in creating a sustainable, adequately funded and resourced community-based mental health system of voluntary services and supports. You know, in Connecticut, we have a coalition called the Keep the Promise Coalition, because decades ago, our governor promised, when 2 of our large state hospitals were closed, that they would reinvest those savings in our community-based system of care. That promise has never been kept. You know, we tried to put political pressure on the governor and his administration before the lawsuit was filed, by having members of our coalition, members of the peer-run advocacy organization in our state, Advocacy Unlimited, putting together a sign-on letter that demonstrated that it wasn't just the lawyers and paralegal advocates at Connecticut Legal Rights Project that cared about this, but it was people from the community who cared about this and recognized the danger that our folks who were locked up in the state-operated facilities faced, and wanting to see something done about it.
Next question. Beyond Section 8, are there other specific federal or Massachusetts state monies for permanent housing to transition folks into the community?
Well, I mentioned the mainstream vouchers. Also, there were some, there was money that was basically sitting with the federal government that had not been allocated to states, that now got allocated to states. It was a good chunk of money. It's never enough to cover all of the need that is out there, but it, those allocations, I believe, were made. I think it's online where they went, what states I think got them. But that is certainly one source. And, you know, some states, many states have something that is, sometimes they call it a bridge housing voucher program, where, you know, it's their own voucher program. Sometimes it's permanent, but often the idea is it's a bridge because it's for a limited period of time until that person can get onto a federal subsidy, understanding that because the federal subsidies have typically not been sufficient in numbers, that, you know, that's why often it helps to have something that will enable the person to get into housing in the meantime and buy time until, you know, that person can get transitioned off and onto a federal subsidy. There's additional Section 811, what's called project-based funds. And by project-based, what I mean is not a building full of people with disabilities. It's a newer program that is supposed to be more integrated, where no more than 25% of the building can be these units set aside for people with disabilities. It's not as ideal when you can't pick the unit. You know, you can't just take a voucher and go get a place that works for you and that you like. Your choices are more limited, you know, when you're talking about these project-based vouchers that are attached to a unit. But they are another option, you know, and they, you know, when you're talking about trying to get people out because of a risk of death, I think they are certainly, you know, an option when they're available. There's, I think, more going forward that, you know, states can do with their tax credit programs. And I am not a kind of housing tax credit expert, but, you know, when they have their processes of kind of allocating units and a fair housing plan and figuring out that their housing is going to go to, you know, in some equitable way, you know, reasonable numbers of people who need it. The tax credits are often used to try to ensure that the, you know, housing is targeted to people coming out of institutions. In fact, some of that 811, that's a federal program, but the mainstream housing vouchers are 811, and these project-based units are 811. That is specifically for people with disabilities, and the project-based units were set aside. There's a preference specifically for people coming out of institutions. And so, you know, it is possible for states to really preference and do housing plans that take into account the needs of people with disabilities, and to try to implement Olmstead. the federal government recently took away what I thought was a pretty strong fair housing rule that, well, it took away a couple of them, but that really required strong consideration of Olmstead in these fair housing processes, and HUD basically eliminated all of the Olmstead stuff from that rule, which was really pretty unhelpful. But nonetheless, it doesn't preclude states from doing the right thing. And so, there are tools. Obviously, that takes time. It's not, that doesn't make fair housing available tomorrow. But I do think that there are a number of federal options that really should be explored. And there's also, frankly, nothing stopping states from, other than budget, obviously, which is not insignificant, but you can raise the stipends that you give for people to get supported housing, and you could raise it for certain areas. You could raise it for people coming out of institutions. You could raise it for people coming out of institutions where there are COVID outbreaks. I mean, there are things that you can do, I think, with state monies as well, that are targeted and limited.
Okay, I just want to point out we have 10 minutes left and there are currently 18 questions in the queue. So we're not going to get to them all. I'm so sorry, but I'm trying to condense them as much as possible so we can get to as many as possible. Are there attempts to make this new SAMHSA standard the regular standard for use of inpatient options?
Well, I think it should be, but I won't say too much, but I think with the current folks at SAMHSA, I suspect it is unlikely, but it would really be a matter of who is running SAMHSA after that, and we don't know that yet. So
this is Kathy. The other thing I'd like to add is that civil commitment is a creature of state law, so it would really matter on what's going on at your state legislators. And I know that we in Connecticut at CLRP are looking at potential amendments to our state civil commitment statute.
And I would actually also just add, Delaware changed its civil commitment statute in the middle of their Olmstead settlement with the Justice Department, because one of the things that the court monitor found there, who's our old CEO at the Bazelon Center, was the court monitor, and looked at some of the civil commitments that were happening into the state hospital and found some really weird things, like people were being admitted for grounds such as lethargy and things like that. And so anyway, they tightened up the civil commitment standards. I know that there is this big push nowadays to, make the civil commitment standards looser and looser and looser, notwithstanding the constitutional requirements, but they actually made them tighter, which I thought was important for purposes of promoting Olmstead compliance.
Next question. What is the increased risk of COVID if you're in a facility, and how is death rate defined?
As far as what is the increased risk rate, I don't know, how one will calculate that. I can just tell you that overall, I think nationwide, all of the studies that have been published seem to say that something like more than 40% of the deaths from COVID are people who are either living as residents or working as staff in congregate care facilities of one sort or another. And I forget, how was it risk defined? How is
death rate defined?
Death rate defined. Yeah, and I don't know. I mean, obviously states, I think, are reporting that differently. I don't know in these different studies, how they're being reported. One thing that has happened is in some states, sometimes they don't count deaths if they happened in the hospital as opposed to in the facility where someone lives. And I think people have been, to some extent, when they do these national studies, trying to get to the bottom of that and creating some standard that actually reflects real deaths and not, eliminating all of these deaths of people who lived in that facility simply because they actually died when they got to the hospital. But I think that's an ongoing issue.
Next question. If there's an issue with private community placements refusing to take people from release because of lack of staff or PPE, et cetera, is there a remedy against the state, and what is it?
Yeah, I mean, I think that's, part of an Olmstead case, and it's part of, potentially, a Youngberg remedy if the state has the ability to, it's the state's community service system. Sometimes it's county's community service system, whatever, but if the entities that control that system, that plan and administer and allocate funds within that system can, do things to incentivize providers to make more money available to, if it's not a matter of the provider simply saying, I don't want to serve you. If it's that, then I think a state can say, we're taking control of our community system. And, if we're going to give you money, it may be, that this is something you have to do from one RFP to the next or something, but essentially they have the power to control their own system. If they're paying for these services, they have the power to say, this is what we want you to do, right? And you don't have to say, we just have to throw money at people and hope for the best. You can say, we're letting out this contract to provide supported housing or whatever service you're talking about. And, in order to get the contract, you have to commit that you're going to serve anybody we ask you to, or, you're going to serve specifically, you're not going to reject people for these reasons or those reasons. You're not going to reject them because they have a co-occurring substance use disorder issue. You're not going to reject them because they have needs for help with activities of daily living, et cetera. And so, states have done that, I think, to some extent. States have given extra financial enhancements to providers for serving people, where nobody's serving them for different reasons. So I think there are certainly things that a state could do. And that by itself, I think is maybe not necessarily an Olmstead case, but it's certainly part of a, usually comes up as part of a broader Olmstead case where this is one of the things that can be done or one of the remedies that might be available to a state to ensure that people's civil rights are not being violated.
Is there any state that is doing this well?
I think that's always a question that people ask. I don't know that I have a good answer to that. It's sort of, different states do different things well. Different states have done well with different types of services. I'm not sure there's sort of model state that's doing everything in the most awesome way. So I don't know if Kathy, you have thoughts on that.
I think what I would say, it kind of along with what Jennifer said, that even if somebody said, oh, X state is doing something well, I'd want to talk to the people in X state to find out what they think about their system, because I think, as Jennifer said, different states do different things well. And what is the experience of the people who are in that system in the particular state? Because I'm fairly certain that even though Connecticut tends to get high grades on a lot of things and does do a lot of things well, if you talk to some of the folks here, you may get some feedback where things could be better.
How do you assess opposition when the opposition's coming from a caretaker or guardian?
I'm not sure what that question means, but let me just say,
like opposition to integrated facilities, to being in a facility.
Okay. From my opinion, as a lawyer representing clients, I take my guidance from the client if they have the capacity to do that. And even if they have a conservator, as we have a court case in Connecticut that says the individual has the right to get their own lawyer and to get their own legal advice. And the standards of practice for conservators in Connecticut is they are supposed to maximize the person's ability for self-determination. So objection to a particular solution from a caregiver or a conservator, if it was something that our client wanted, we would be zealously advocating for what our client's expressed preferences are.
Yeah, and I would just add, I mean, that is typically, you know, a matter of state law, what the obligations of a guardian or conservator are, but they are supposed to serve the best interests of the person they are the guardian for. And that doesn't mean that you can just sort of ignore and not keep yourself informed about what the options are. You know, in some cases they are supposed to, and I think this is really best practice to actually give effect to what the person wants when it is clear what the person wants. You know, if unless there's some, you know, gross danger, which I, you know, think if the state actually said that the person's appropriate, or the treating professionals or whoever usually is making these determinations offer the person supported housing, and the guardian says, well, I don't want it because I don't think they're going to be safe. I mean, I think the guardian has, you know, a set of obligations that, you know, really is supposed to be to give effect, in at least in some states, to what that person then wants in that circumstance. But you know, in many cases, you have guardians who simply say, I don't want to hear about it. I'm not interested in that. I'm not going to take your materials. I'm not going to show up at your sessions. I don't want to hear about supported housing. I'm not interested in it for this person. And I think that the courts have sometimes said, no, you can't do that. You know, you have to keep yourself informed. And in some of the agreements, I think in some of the court orders actually talks about guardians' responsibility. And I think in the North Carolina settlement agreement with the Justice Department, there's an Olmstead settlement there where there's some information about guardians that is built into that settlement to try to make sure that guardians don't do those things. And it does reflect what's in the state law about them complying with their responsibilities.
So we are at 3 o'clock. I don't want to put the presenters on the spot. Do you want to answer a few more questions, or do you want to end it for another day?
This is Kathy. I can stay on if the captioner and interpreters can, but if they can't, I'd be happy if you sent us the questions that remained from the chat that didn't get answered live. And I'd be happy to respond to people.
Okay, I don't know if the captioners can stay or not. So I guess what we're going to do is we're going to end the call. Thank everybody for their participation, and we'll capture the questions and get you your answers.
Thank you all so much for being with us today. We appreciate our ASL interpreters, Adrian and Brittany, as well as our captioner, Tracy. We will get the recording and the transcripts to you shortly. They'll be posted via the NARPA website. Thank you all so much for your participation. Have a good afternoon.